Bismillah, Assalamu alaikum. We are so happy for all of you joining us today. I see about 200 plus attendees, which is great. Collaboration between the Saudi German Hospital Group and the Jeddah Urology Club. We are having this great evening with Dr. Guy Webster, who is a very well known minimal invasive surgeon. He will share his experiences with us, and the floor will be open for questions after each part of his presentation. We have with us Dr. Suleiman. Everybody in Jeddah knows who Sam Suleiman. He's one of the pillars on which urology based in Jeddah for the last quarter of a century. And we have with us also some very good names from Egypt and also from Jeddah. All of us will have this great, inshallah, interactive session. Please send all your questions in the question and answer and chat. And hopefully we can share our experiences and gain a lot of knowledge from Mr. Guy Webster. And the floor is yours.
Thank you very much, Ashraf. It's a great honor and pleasure to be invited to give this webinar to you all. Good evening to you all in different parts where you are. I apologize, I'm slightly casually dressed. It's Sunday evening here, and I've ended up taking a little bit of leave I was offered because the arrangements have been a bit unusual recently. So apologies, I'm in an open neck shirt, but it's a great honor. I'm going to run through some principles of laparoscopy with you and come on some more specific details. My name's Guy Webster. I'm a consultant urologist in the UK. My NHS practice is in Oxford and Milton Keynes. I'm going to talk a little bit about the history and principles and run through in phases, and we're going to stop at each point to take questions. So just to set the scene, a couple of nice pictures of London Tower Bridge on the left and Oxford University on the right. Won't dwell on this too much other than my training was in the UK, and I did a fellowship in laparoscopy in Australia, which was a little bit unusual at the time in 1999 with David Nicol, who was a professor in Brisbane, who actually now is Chief of Surgery at the Royal Marsden in London. And having been my boss, he's now a good friend, which is excellent. My training in laparoscopy took me to different European countries to do short and longer versions of training. And I've done laparoscopy and then evolved into robotics and back into laparoscopy at some times. Laparoscopy, as you know, has been going on over 100 years now. Started off in Germany and Sweden. But the modern era of laparoscopy, of upper tract laparoscopy, since the early 1990s in North America, basically, Ralph Klayman et al. And most procedures now have been transferred into a laparoscopic setting, even complex things such as live donor nephrectomies. In terms of the principles which are really important, general anesthesia, safe positioning is absolutely vital. The instrumentation, it's important to know your way around the kits, whether you're using reusable or disposable, and to know your method of access and continue it, make it reproducible. Establish a pneumoperitoneum, and then triangulation is the key in laparoscopy, which is slightly different to robotics, which is why I mention it. Different energy devices and different techniques and technology can be utilized for suture and closure, normally extracting in a bag so as to prevent seeding, which is one of the principles. And from an anesthetic point of view, very important, particularly in the early stages when procedures are very long in the early part of the learning curve. Patients need to be well hydrated, kept warm, and thromboprophylaxis is key, because although there's a risk of bleeding in some procedures, which we'll go on to, so is there the risk of thrombosis and compartment syndrome. So what are the advantages? You probably all know these: less bleeding, therefore less transfusion. I think it's pretty established, better view, oncological and functional outcomes in partial nephrectomy and in radical prostatectomy, less need for analgesia, therefore a quicker mobilization and return to home. But there are variants of laparoscopy. We have hand assisted, which some people still do, not particularly popular now in the UK. People either do open or laparoscopic, but as you can see, there's a hand in here through a gel port as well as a laparoscope. Well, what about 12 years ago now, we went into using single port, different versions available, different acronyms, less laparoscopic endoscopic single site or small incision laparoscopic sills, through these single port sites with multiple valves enabling multiple instrumentation. But some of these are really quite complex. I don't know if you've ever, any of those of you who did it or went on the training courses, these can be incredibly complex, particularly with sills, where the instruments are actually crossed over to increase your angulation, which can be really quite difficult. Therefore, some people favor changing their hands over, crossing their hands over, so it kind of reproduces what they're looking at. So on the right, you can see by crossing over the hands, you therefore reproduced your double crossing. Oh, how do I go back to? Notes still around. On the left, we've got a trocar coming up through the vaginal fornix into the pelvis of a female, with a very fancy narrow endoscope on the right with multiple functionality down 4 separate lumens. So there are different choices of access. Gynecologists in the UK tend to use the Verus needle, but we in urology tend not to. We think there's too much of a risk, and we therefore use the Hassan cut down and put a trocar in. I think if you're used to the Verus needle, you can use it, but there is a significant risk of morbidity. So I've always utilized the cut down, and the more experience I got, I found I could do it fairly safely, even in high body mass index patients, although that was a little bit challenging initially. And some people using the optical trocars, where you put the laparoscope down the visualization trocar, and the picture on the right, you see subcutaneous fat as you're going through that part and on the entry into the peritoneum, and you dilate as you go. So transperitoneal is very familiar. We tended to do our training in general surgery, didn't we? So we were used to laparotomies, and the anatomy is therefore familiar, and there's lots of space, and it's versatile. However, with retroperitoneal, some of us trained in open retroperitoneal techniques. I like it because it gives you easy, straightforward access to the renal artery, which is posterior, and you can go in posteriorly, avoiding the hostile abdomen in patients who've had multiple laparotomies, for instance, for inflammatory bowel disease. But it is unfamiliar, and it takes practice, and you need to dilate the space. And there's increasing evidence, and my experience is it causes less ileus, and the discharge is a little bit quicker. But the positioning is very different. And if you swap from one to the other, you need to be aware of the difference. Retroperitoneal, the table's broken. Transperitoneal, the table's flat. So transperitoneal, something like this, with the table flat and tilted, patient slightly tilted posteriorly, and the ports are centered around the umbilicus. That's your key point. So this would be for a left-sided nephrectomy, say. And the familiar view, this is left side, see the spleen, pancreas being taken off, perinephric fascia, Gerota's fascia there, lots of space. For retroperitoneal, the table's broken to increase the space between the costal margin and the hip. And it's all centered around the tip of the 12th rib. You can see here with an X, II. The tip of the 12th rib goes slightly inferior caudal to that and anterior. And that's your starting point, and you're centered around there. Then with ports 2 and 3 are your instrumentation ports. Retroperitoneal, the view is a bit unusual. This is the view you see first of all, with psoas muscle horizontally at the bottom of the screen, and you've got Gerota's fascia in front of you, which you need to open up. But the advantage is you get to the artery pretty quickly, and you can see it pulsating initially. Less easy in people who have got a high body mass index, but you can get to the artery, and you get to the artery first, which you can therefore occlude. I'll leave this slide. Complications, I'm sure you're all aware of them. When we started doing more high volume laparoscopy, it was important that we communicated this with our non-surgical colleagues in the hospitals and also in primary care, so they knew what to look for. I think the thing I'd highlight is shoulder pain, which the patients can have extremely severely for 24 hours or so afterwards, thinking, you know, they worry themselves that they're having some ischemic cardiac event. And it's important that we warn them of that and consent them for it. I think laparoscopy is all about practice, regular suture practice, being versatile, but also methodical, having a system. Be prepared for long surgery when you start, and think about sitting down. I actually haven't traditionally sat down. That's just the way I was taught, but I am aware of some people who have the table a bit higher and do sit down. And I think that's more comfortable, and work as a regular team with an anaesthetist and assistant around you. Lots and lots of practice. On the right is one form of a trainer made by, as you can see, Eye Surgicals. And on the left is the Orsi lab where I did some of my training, which is in Brussels, just outside Ghent. You can see lots of Stort's laparoscopic trainers there. So I don't use the Verus needle for access. I know it's about minimally invasive procedures, but I think that if you use a 10mm port, it's a little bit more versatile. I guess the thing I learned really was to be prepared to put in another port, and it's not a sign of failure putting in another port. I sometimes in my early experience struggled a bit with minimal ports, you know, 2 or 3, whereas I should have put in an additional one. If you get bleeding, plan for it, don't panic. Tell the anaesthetist, increase the pneumoperitoneum, put in tonsil swabs to absorb the blood, because the blood otherwise absorbs the light. And I'd suggest you always have an full open surgical set available. Don't be brave or foolhardy, but always have an open set available at standby behind you in the room. And I think pyeloplasty is a nice procedure to learn on, benign, although it is reconstruction, so it's a little bit complicated. My advice I was given, which I think was useful, to remove the stent 2 or 3 weeks beforehand, just to try and remove that, reduce that inflammation that can otherwise be present in the ureter, meaning that sutures can cut out. So try and remove the stent if you can plan for it a few weeks preoperatively. Stent retrogradely through the bladder before you do your pyeloplasty, so you can just concentrate on the pyeloplasty. But when you become more experienced, you can stent antegrade once you've divided the ureter from the renal pelvis. The benefit of that, having not stented it, is you've got a nice dilated renal pelvis, which is easier to dissect. Continuous sutures are easier and quicker than interrupted, and I use one anterior, one posterior. I actually do my pyeloplasties transperitoneally, so I tend to do the posterior layer first because it's a bit more difficult. Think about using a barbed suture, but try to avoid the small intrarenal pelvis because these can be incredibly difficult, suturing up in the essentially up in the hilum of the kidney. I'm going to just show you a little video now, hopefully, which is going to show you a retroperitoneal access to actually a horseshoe kidney, and it shows the beauty of the retroperitoneal approach. So it's a horseshoe kidney, right-sided moiety is dilated, as you can see on this CT. The renogram curve shows it's obstructed. This is in a young man who had multiple laparotomies for Crohn's disease. And it was a retroperitoneal approach, direct visualization of the cannulas coming in, which I think is important. I'm going to speed it up at times. This happens to be a robotic procedure, but I don't think it matters. Then that's Gerota's fascia, which you open up, and you can see you're directly down into perinephric space. This is a slim man, perhaps because of his Crohn's disease, and the anatomy was different, but became into view fairly quickly. dissect around the kidney. There you can see the ureter, and the kidney is being slightly held down. You can see the ureter coming off down to the right, and that is mobilized. We've got some aberrant vessels here which are clipped, as you often find with a horseshoe. These are venous, so of no concern. Hemostasis is obviously paramount in all surgery, but particularly in laparoscopy. There's a fairly small renal pelvis because it's already been stented. We're going to open it up. I'm speeding this up for ease of viewing. And then vicral sutures, 3/0 vicral sutures used in an interrupted fashion in this, with the patient already stented. Closing the posterior aspect, making sure that the upper proximal loop of the stent is in the renal pelvis. This can be done, this is robotic, but it can be done laparoscopically, as I'm sure very many of you are aware, as long as you practice your technique sufficiently. So I guess we could stop there, because that's sort of the end of my pyeloplasty section. And because then I was going to go on to talk a little bit about partial nephrectomy. So I'm happy to take questions at this stage if that's useful on pyeloplasty.
Sure, that was great so far. From our panelists, maybe we should ask if they have questions themselves first. And please, for our audience, if you want to type in your questions so we can direct them to the speaker.
Thanks all, if you allow me, Dr. Ashraf. Thanks to Dr. Iftar for the presentation. It was great. I agree with you. It's very crucial to have the team in the OR when we do laparoscopic surgery, especially when you start. It's very important to have an assistant who knows how to hold the camera, how to help you, and you start practicing outside the OR, and then you continue that. Now I have a question for the pyeloplasty. When you do it transperitoneal, do you use interrupted or continuous?
So that video I've just shown is interrupted, but I tend to do it continuously. I basically reproduced the technique I was shown, in the open classical Anderson-Hines pyeloplasty. So I tend to do transperitoneal for pyeloplasty, do the posterior layer continuously, then I do the anterior layer continuously, and then sometimes use a third suture to close any additional opening of the renal pelvis which is present. So I tend to continuous.
And for the stent, you said that you would remove the stent 3 weeks ago. Now there is a trend of doing that to reduce the reaction inside the ureter. So when you do suturing, it would be much easier. You don't have a thick ureter. Do you put a nephrostomy tube like 2-3 weeks before, and then put a stent intraoperative while you're doing the procedure?
No, that's an interesting variation. I've never done that, and I've never really thought about doing that. My concern of taking out the stent preoperatively, and I think it's quite a good thing to do, because I have had the experience of doing a couple where that have been long-term stented and been incredibly difficult to suture, and it just tears through. But my concern is in the scheduling, that the patient gets cancelled for whatever reason for their procedure, and then they're left unstented and then get problems. So you have to be very tight on your scheduling to ensure that it's only 2 or 3 weeks. But no, I haven't done a nephrostomy, but that's a really interesting way to do it.
Yeah, because I've seen it before, that they do nephrostomy tube before 3 weeks, 2 to 3 weeks before surgery, just to rest the ureter. So that will help in reducing the inflammation around the ureter and inside the mucosa, because sometimes the stent itself, it causes a lot of reaction inside the renal pelvis mucosa and the ureter, and that would be more difficult to take suture and to spatulate.
Yeah, that's very interesting. No, we don't do that. And is that done by the interventional radiologists, or do you have a practice of doing the nephrostomies yourselves as urologists?
No, that's interventional radiologist.
Yeah.
No, how easy is putting the stent intraoperative? I've tried it in a couple of cases, and I have to say at the beginning I found it very difficult to put a stent, while after taking the first suture or after spatulating, you put the stent and then you take the suture. How do you do it?
It can be difficult, and when you first start, because you're concentrating so much on doing your suturing, it can be really quite frustrating when you're trying to put the stent in. So the way I do it is by selecting where I'm going to put it through the anterior abdominal wall and putting in a cannula, a large gauge cannula, taking the needle out, then feeding the guide wire through the cannula, and directing that down the distal ureter, and then sliding the stent over the wire. But then you need to make it still slightly bigger with a blade, I've found. So with a scalpel, I then make a slightly bigger incision, feed the stent over using a pusher. Again, it's about an assistant. You need an assistant who is confident and comfortable with this to push the stent in, and then push it in. And I mean, one criticism of this approach is that if you've got a distal ureteric stricture, you can get into all sorts of trouble. And I have had that on one occasion. The data suggests that distal ureteric strictures might be present 10%. I think it says 10, 15%. I think that's high, but I have had one. I could not negotiate it antegradally, and I ended up having to reposition the patient and do it antegradally. And at that point, I kind of regretted it, and I moved my technique, but I went back to it. So, I think that's unlikely, and I think it's worth pursuing. It's quite satisfying when you are able to do it.
Yeah, the question is about the distal tip, as you said. I had a case that without a stricture. I mean, we tried to put a stent, and we thought it's in. It called into the distal ureter, and I have to take the patient the next day just to reposition that tip of the stent. So it can happen. That's why I do retrograde before doing the procedure, or at least I have to make sure that the patient has a retrograde. So to make sure that we have only one pathology at the upper ureter. We're not dealing with different pathology in the ureter, and then you get surprised after starting your suturing and trying to put a stent that there is a problem in the distal ureter.
No, I think, that's a very, very valid point, because it's incredibly frustrating if you do come across it. And I think, there are many very experienced pyeloplasty surgeons who will always do a retrograde stenting, first of all, just to see the retrograde, to know they can get the stent in and not bother doing it antegradally. So, maybe it's a bit of a shortcut, which when it works well is useful, but can be very problematical if it doesn't. I take that on board.
Or I use a small stent, 4.7. That's even will make it easier when I cut or try to spatulate the ureter while the stent is there. Yeah, so I start with the retrograde, put a stent, a small one, and then when I cut, I make sure that I don't cut or I don't nick that stent. So this is very crucial. Even when we cut through the ureter, you don't want to injure that stent, because that part might cut and left behind when you try to remove the stent later, like 3 weeks after surgery or 4 weeks after surgery.
I agree. So I also use a small stent. I don't use a 6 or 8 French like the radiologist will put in. I put a narrow one in for exactly that reason, so you can get the tips of the scissors in to spatulate the ureter. Yeah, and some people, and I've only done it a couple of times, I find it quite fiddly, but some people will fill the bladder with methylene blue, so that when you put the stent in, you get reflux up the stent, out of
what I do sometimes, I put three-way Foley catheter and the stent. So what helped me is sometimes when I need to distend the renal pelvis, I just fill up the bladder, and that will fill up the bladder. fluid will go up into the renal pelvis, and then you see it extended. Or you use open tip ureteric catheter and inject to see the renal pelvis, and you see where is your stricture, and then slowly you can remove that and slide a wire through the open tip.
Yeah, I mean, I think it's really important to know what it is you're dealing with, and so all these patients should have, you know, cross-sectional imaging, have CT urogram, so you can see what the situation, not just an ultrasound that shows hydronephrosis and a renogram showing they're obstructed. You need the surgical planning as much as you can, because like with all laparoscopic surgery, if you start having to do reconstruction, it can get extremely frustrating, and you know, you're in one limited position with the patient.
I have one more question, but I will leave it later. I'll give the chance to Dr. Ashraf.
Okay. Yeah. For our panelists, any more questions in that part? So if there is none, Mr. Guy Webster, maybe we should go ahead with the nephrectomy tips.
Okay, thank you. So, yeah, tips with doing laparoscopic nephrectomies. I personally think retroperitoneal access is very good, but it's very difficult then to get the bag in because there isn't much space. But I think it's worth pursuing and trying to do it. Sometimes the whole bag won't actually get in the space. Try and avoid, this is about case selection and trying to get appropriate numbers, but try and avoid the English expression of the simple nephrectomy, which is not simple. These benign cases can be extremely challenging, particularly long-standing stones in the renal pelvis, particularly on the right side. They can be adherent to the IVC, and those that have got CT characteristic changes of XPN, xanthogranuloma, pyelonephritis, I'd try and avoid those because they can be extremely difficult. And then it affects your confidence if you have to convert. If you need to convert, you convert. So left side is easier. Avoid the tumor thrombus in the renal vein because that can, you know, it can just cause excessive bleeding issues and a lot of collateral circulation. One little tip is to put a swab under the renal hilum when you're doing your dissection. It seems to just put the hilum anteriorly. I like the diathermy hook for using the very small lymphatics around the renal artery. And if there's two veins, which seems to be quite common, and you're having difficulty accessing the artery, just clip one of the veins to get it out of the way, and then go to the artery, because you need to clip the artery first, and then go on to your second vein. So don't think you have to be incredibly systematic doing the arteries and then doing the veins. As long as you've got venous drainage, you could do that. Some people staple. I've done it a couple of times, but I have had a stapler failure, which made me nervous. There's big series in the UK where people are just using a stapler to cross-clamp the whole hilum, but you need to make sure that the tip of the stapler is all the way across. And by and large, you leave the adrenal gland alone and the adrenal vein alone. Nephroretrectomy, I mean, that's a whole talk in itself. The way I tend to do it laparoscopically in terms of the distal end is I do an upper tract nephrectomy laparoscopically, and then I do an open lower end through a transplant incision, because you're going to retrieve the kidney anyway. And I think it's nice to have direct visualization into the bladder, possibly suture it directly, so you don't have to have catheter drainage for too long. But there's different mechanisms that are widely published. Partial nephrectomy tips: go for peripheral small tumors, ideally not biopsied, because some of them get a lot of intense fibrotic reaction, which can be difficult. There is a bit of a move to biopsy in the UK for small renal masses to confirm they're malignant. Pick slim patients and try and get into the practice of slooping both the artery and the vein, and which I didn't do, but probably should have done early on. And I just sloop the artery and put a bulldog on the vein for central tumors, because they can have extremely significant back bleeding from sort of venous backflow from central tumors. And this has been transformed with the sliding clip technique. but you can do it. It's reproducible, open, laparoscopic, robotically. I do an internal closure with either one or two, normally a 4O monofilament, PDS or Maxon, and then I tend not to unclamp, although some people go for early unclamping, but early on probably shouldn't. And then do your cortical closure with a nice big needle, nice big suture, an ovicral, which is absorbable multifilament, one suture for each centimetre of defect, and then put either two hemolocks or a hemolock and a laparoti on each end, and visualise at the end with a lower pneumoperitoneum. This picture shows the principle of the sliding clip technique, but I'm going to show you some videos now kind of highlighting what I think are really important points in the partial nephrectomy, starting with a quick video of
Do you do most of your partials retroperitoneal also, or you do it transperitoneal?
Oh, so no, I do them transperitoneal. So I do my pyeloplasties transperitoneal and my partial nephrectomies transperitoneal. But the nephrectomies I try and do retro. Now, one of the reasons for this is that I evolved from laparoscopy to robotics, and I did find it quite challenging to do the hilar dissection and find the artery behind the vein. So I kind of got better at doing transperitoneal procedures in having done them robotically. So I've done some retroperitoneally, but in terms of robotic, it's really quite challenging in terms of the space, because you've got to get 4 different instruments in. So I tend to do it transperitoneally. This first video shows the arteries. You see it slooped with a yellow rubber sloop and a hemolock clip at the top, and the arm bringing in the bulldog. And I think it's, you know, this is a really nice technique. Sloop it and then clip it like that. Then in terms of tumor excision, I used to use diathermy because I was a bit sort of nervous of diving and cutting into the kidney. But I think the right thing to do is just to use your scissors, be confident from planning where your tumor is. This isn't one of mine. I borrowed this from Craig Rogers, who you probably all know, who's an excellent robotic surgeon. And it's about, again, assistant suctioning the blood and making sure you can see good renal parenchyma that looks normal, not tumor, and just, you know, be confident, plan it in your head, and cut with cold scissors, not diathermy. I think it slows you down too much.
What about the use of, in partial, the use of intraoperative ultrasound?
I've used it a couple of times, but not very often. There are people, I mean, so I think if you start doing a lot of endophytic tumors, they can be really quite challenging, and possibly there's benefits. So yes, I have. So for the endophytic ones, yes. But for the exophytic ones, not particularly. I find it quite difficult. Not only is it quite fiddly to actually introduce it and have a look, utilizing your laparoscopic instruments on the clip, using the attachment on the ultrasound, but I find the images are quite difficult to interpret. So yes, I've done it a couple of times, but not routinely. Then this just shows the principle of doing the inner layer, the inner renorrhaphy, to close obvious collecting system and any obvious bleeding that is happening, using a monofilament that's brought in from the outside of the kidney through the cortex and then clipped. So two separate layers, the inner layer, which is in the bed for the vascular hemostasis, but also closing any of the collecting system that you can see that is open. No.
I have a question, Professor. My name is Dr. Sam Sliman. Do you think that soft clipping of the pedicle can provide good hemostasis in most of the partial nephrectomy cases?
Say that again, soft clipping of the hilum?
Yes.
Well, I mean, you might be alluding to the fact that sometimes you think you've done a fantastic operation and on the scan you identify what you think is one artery and you clip it and you go to do your tumor excision and it bleeds significantly. Whether that means there are additional arteries which you have to look for, or whether your soft clipping is not working, I don't know. So some people will put more than one clip on, they'll put more than one bulldog on, and they'll be more confident putting two on because they feel that there's not enough closure, particularly in the elderly patient with atheroma in the renal artery. So you've got a lot of, crystallized intima, which isn't necessarily occluded by the clip. So I think in a lot of the videos you see, there is significant, not significant, but it is not bloodless. Is that the point you're making, that despite putting the clip on, it still bleeds? And then, yeah.
Dr. Webster, I would like to ask about using the cold scissors. No matter the size of the tumor is, I think whenever it's bigger tumor, it will be more vascular, and using a cold scissor will be more bloody in the field, I think. What's your opinion about this?
No, well, I tend to use scissors for whatever the size of the tumor is. But I used to sort of dabble on the surface, making myself feel a bit braver by diatherming on the capsule. But no, I think your scissors have got to be sharp. As surgeons, we all appreciate that, and I think if they're sharp, no, I use scissors irrespective of the size.
If you don't mind, using the scissors is very crucial here for two reasons. First, that when you use the cautery, you don't see your margin. It will be black all the time while you're cutting, so you don't see the margin. And then the pathologist will tell you that I cannot see the margin if you have a cautery artifact. This is one thing. The other thing is, when you cut, you can see if there is a bleeding point. Then that's the time when I use the cautery. Just at that, if it's too much, I just put it to mark it. So when I do the suture, I can come to that point and suture it exactly. But cold scissor, and if you use the reusable scissor, it open widely. So it's not the disposable. Disposable, the opening is very small, but the reusable is very big, and then you can cut it. It comes faster, especially when you have a good clip on the artery. You don't have that much bleeding, so you will see clearly, and then you can take it without leaving a lot of artifacts from the cutter.
No, I mean that's all very valid. I've sort of talking about some specific steps here and sort of missed out the fact that, because what you're alluding to is really important, that you use your scissors to put diathermy marks on the capsule to show yourself where you're going to put your incision, and it's about mapping it out as much as possible so that you're clear in your mind, and that comes with experience, having that confidence of being able to transfer those CT scans into a 3D visualization. Now, in some places, they have wonderful software, so you can get rotating 3D images of the tumors, and we've done that occasionally, and they're beautiful images, and it does make it a lot easier, because I think that's really quite challenging otherwise, knowing, because you lose your way when you're going into the kidney. But I think we know from experience and from large case series, if you find yourself going into tumor and you do and you can visualize it, you need to recognize it, and then you need to go deeper. Leave it as a little flap, go deeper, go around, and very importantly, put on your request form, inform your histopathologist that you went into tumor, otherwise they will put it down as a certain positive margin. but the case series would indicate that it doesn't increase local recurrence rates as long as you visualize it, which is why the vascular hemostasis is key, the ischemia, and having a good assistant who can keep that sucker in the crevice, suctioning that blood away.
There was a question about using the cold ischemia in laparoscopic partial nephrectomies. Is there any advantage of trying to exactly replicate the open procedure by using the cold ischemia in the laparoscopic cases? Have you done it? Like, I've read a lot about it, but I've never done it. It's not that practical, especially when you have an experience. You can do your resection and at least initial closure in less than 30 minutes.
Exactly. So I think, you know, we're all familiar with the fantastic work that Novik did on partial nephrectomy from the Cleveland Clinic, where he used to use a lot of ice slush for open, or they would infuse very cold saline retrogradely up the catheter. But I think as techniques have improved, I don't think so. I think as long as you can get your warm ischemia times to, I mean, it depends on the renal function, but if you can get them sort of under 30 minutes, I think that's reasonably satisfactory. So I don't really think there is a role now, no. This just shows the closure, big needles from the defect through the cortex, and then putting a Hem-o-lok clip on. So bridging the defect, taking a nice bite either side through the capsule. Now, in this video, I don't know what those who in the audience who do partial nephrectomies, I've stopped putting bolsters in.
Exactly.
I found it really hassly, to be honest, and often slowed me down, and I found it a bit frustrating. So I think the sliding clip technique is so good you don't need to put a bolster in, but I thought I left this in as a reminder to mention it, because I think most people don't actually do it now. So you pull it up, you put your Hem-o-lok on, and then you slide it down under tension, and you get a nice closure that way. But you need to put on another Hem-o-lok or a Laparoscopy, but probably best done after the artery is released, so you've got blood flow in the kidney, because it will expand slightly.
And even Laparoscopy, I think a lot of people, they stop using it because it's sometimes because it's very small. It just it's so difficult to put it over that stitch. For the people who doesn't know the Laparoscopy, it's this dissolvable vacuolar clip that usually we put after putting the Hem-o-lok, just to stabilize the Hem-o-lok. So if you can slide the Hem-o-lok toward the kidney, the clip can slide by itself back. So to fix it in place, you put that Laparoscopy, the blue one, just to fix it in place. I used it only once or twice. Then I found it very difficult just to for the assistant or for me, especially when you do laparoscopy, to go and find that stitch and put that Laparoscopy.
Yeah, I mean, I have to say, I don't, probably perhaps the same reasons, I don't use a Laparoscopy. I use 2 Hem-o-lok clips, and I'm very comfortable with 2 Hem-o-lok clips where the suture is placed at the, you know, roughly in the midpoint of the clip, rather, because I think that's where your maximum closure point is, rather than at the end. And again, that's, you know, comes with comfort of having a good assistant, making sure that the suture's going through the middle. So no, I use 2 Hem-o-loks.
I think the Laparoscopy is from the open surgery era, and it's now fading out of favor. A couple of things about your partial nephrectomies. Do you do any enucleation technique for your smaller tumors? This is one thing. The other thing, I want you, please, if you emphasize that partial nephrectomy is not a laparoscopic surgery for any beginner. It's really the most difficult, in my opinion, out of all laparoscopic surgeries. And you need to be more to the expert side to start doing partial nephrectomies.
Second point, I completely agree. the challenge of a partial nephrectomy should not be underestimated, because they can be extremely challenging, and you need to be incredibly methodical. And in the early stages, even if you're quite experienced as a nephrectomist, and I think you probably need many nephrectomy cases under your belt before you start doing partial nephrectomy. That they are very challenging and not to be underestimated. I agree. What was the first point? What was the first question?
The first point about the enucleation.
Oh yeah. So yes, I do. I mean, it's been shown that enucleation is something that can be done, reproduced quite nicely in terms of oncological outcomes, because the renal cancers have they seem to have a pseudo capsule on them, and it takes a bit of time to get used to, doesn't it? It's not something that comes naturally initially, but as you do more and more, and you can start sort of using the scissors closed. I use it with the scissors closed and sort of fracturing the tissue around the tumor, but sometimes going, around the capsule. If I'm happy, I've got good visualization. So I think that's the other key. If you've got good ischemia, I think an enucleation technique can work quite well with good visualization.
For very small tumors, yes. For tumors that 3 centimeters or less,
correct.
This is what we are usually now using as standard.
Correct. I agree. Small renal masses, small tumors, 3 centimeters and less. Yeah.
Because the larger ones tend to not respect that capsule very well. They have like finger-like extensions out of that capsule, and that was proven by the studies that came from USC. That the larger the tumor, the less favorable the enucleation technique oncologically.
Yeah, I mean, I was very nervous about enucleation initially. Some of my visits to very experienced partial nephrectomy surgeons showed me that you can do it, but again, it's not for the beginner. I don't think it's not for the beginner early on in their partial nephrectomy series. I mean, I've got some slides on robotics. I don't need to talk too much about that. I think we're all aware of how we've moved on from laparoscopy to robotics for most procedures. Either the Da Vinci, the standard, or I don't know if you're aware of this, the Vercius robot, which is starting to be sold in certain centres around the world, including in the UK now. It's a modular one where you have integrated modular arms, so it's different from the Da Vinci, which is sort of all in one. But the advantage is it's cheaper. So many units are starting to buy these. It's got lower running costs. The whole thing is cheaper, but it's still a very good robot going through accreditation processes at the moment. And the console is a simpler version of Da Vinci, but I've used it. We have one in the hospital, and it's good. And I watch this space. I think you'll see a lot of these robots around the world over the next year or two. In the UK, we're doing partial nephrectomy and prostatectomies robotically. Not many nephrectomies as such are done robotically. I'll run over this because we've talked about hemostats. Just to say that we're doing a lot of renal biopsies now in the UK for small masses, because we know that 20% or so can be benign. So we do biopsy them, but sometimes they can result in a very tricky fibrotic partial nephrectomy. Shall I stop at that point, or I was going to go on into my, we've had some questions, so I might just go on through to show some sort of relevant slides about laparoscopy and COVID. We all know what COVID is. I'm sure we have been affected quite badly in the UK. I think we're up to 45,000 deaths now. It's an RNA coronavirus. Different studies show different rates of contamination of the urine, so urologists were really quite nervous initially, and one of the studies showed in 4% of urine samples. Others have said it wasn't, but it's known to be in blood and throughout the gut. And this is important because laparoscopy can be aerosol generating by definition. And we know HIV, hepatitis B and HPV have all been identified in diathermy smoke, but there's no definite evidence that SARS-CoV-2 coronavirus is in diathermy smoke.
Yeah.
But there's nervousness around it, and I'm going to just talk about one of the big study that was in the Lancet that needs to be factored in, because we're talking about laparoscopy because it confers significant patient benefits in terms of reducing inpatient stay. An inpatient stay in the environment of COVID within a hospital is obviously a good thing in reducing their exposure. But this paper from the Lancet came out a couple of months ago, where they looked retrospectively, multi-center, many countries. They looked at patients who were having emergency and elective surgery and were found to have COVID on antigen testing between 7 days pre-op to 30 days post-op. And in terms of the patient characteristics, 3/4 was emergency surgery, 55% was benign, cancer surgery was 25%, slightly more males. Interestingly, only 3.3% was urological. The big players were general surgery and orthopedics, sort of 30% each. But the results showed that the 30-day mortality was 24% if you got coronavirus as an inpatient during your surgical stay. And if you're over 70, if it was emergency surgery, if it was cancer surgery, ASA, perhaps no surprise. If it's above 3, the mortality rates were higher, and the conclusion from this was that we should be delaying surgery if at all possible in the COVID environment. Now, most of the urological association, BAUS, general surgeons in the UK, the American groups, SAGES, European Association, all brought out guidelines about safe laparoscopy. And the principles of this is that basically we should avoid performing cases if we can do so. And we should try and perform them in clear, clean centres. The patients in the UK, what we're doing is ask them to isolate 14 days preoperatively for elective surgery and having antigen testing at 72 hours. And in some centres, a CT of the thorax as well. But as surgeons, the important thing is that we avoid being around the induction and extubation process for about 20 minutes or so, because that is without a doubt aerosol generating, and we need to try and avoid that. And we need to have minimal personnel in theatre. We need to have a regular team, even more so than normal. Experienced surgeons, maybe 2 surgeons because everything's going slower, because of wearing PPE. Use WHO checklists, which is commonplace in the UK, but really important in this because the communication is really difficult with these FFP3 masks on. So we want to know what we're going to be doing throughout the procedure in advance, and then putting filters and smoke extractors on the laparoscopic equipment. Balloon trocars I like anyway, but they reduce gas leakage, reducing valves if you're using a robot. Try and take specimens out in bags because again the seal is better, and have a low pneumoperitoneum. Avoid venting, which means opening up the ports to let the pneumoperitoneum out, but suction it all out laparoscopically. And if you have got these air seal SurgiQuests, to use those for continuous circulation. And maybe avoid harmonic scalpels. Those of you who use harmonic scalpels, it creates an awful lot of smoke, and it's quite low temperature, so it's perhaps not as virucidal as diathermy. Don't put drains in. So on the left, we've got a picture of the air seal made by ConMed. It's a really nice piece of kit which maintains the circulation all the way through. For those of you doing partial nephrectomies, when you've got a bleeding partial nephrectomy with a lot of suction going on, evacuating the pneumoperitoneum, it maintains a steady state pneumoperitoneum on the right is the balloon trocar, which I personally use generally anyway for laparoscopy. I think it's wonderful in terms of maintaining a seal. And this slide, nicely summarizes everything that I've just said, really, but all in one slide. And I think we need to be very cognizant of this and be doing things appropriately. We in the UK have prioritised our surgical cases into 5 levels of emergency, urgent, surgery that can be delayed up to 4 weeks, up to 3 months, and more than 3 months. And a lot of work has gone into this. So our benign cases we are postponing, but some of our cancer surgery, whilst we postponed it initially, we started to do it. And I thought this would be useful. You could see our sort of schematic representation of what we felt we should be doing. So on the right, stage 4 is emergency cases. They're being done anyway, obstructed kidneys, testicular torsion, etc. We stopped all elective surgery, but then started to reintroduce high-risk cystectomy, renal tumours that were bleeding, or T3 disease, high-risk TURBTs, high-risk nephroretrectomies, so people who'd had a biopsy and were known to be high-grade, and the lower-risk nephrectomies, and lower-risk TURBTs, lower-risk cystectomies were in a further stage of delay. And this is basically how we have been operating recently, and we are reintroducing our cases, and we're in a recovery phase now, but we are now doing some stage 2 cases, but we're not back doing stage 1, and we're not back doing benign cases, for instance, pyeloplasty. So at that point, I'm going to say thank you very much for asking me to speak. It's a great honour and a privilege to speak to you all. I hope that's been useful. And if you wish to ask any further questions, please feel free to do so. Thank you.
Let me thank you for this great presentation and sharing your knowledge with us. We learn from each other, and I think the knowledge now spread very well through webinars in these COVID times. That's maybe one of the benefits of this pandemic, that made the globalization of spreading knowledge is quite the standard now. We needed something to wake us up and let us use this technology more and more. And it's great. The panel is open. One point only before that we start questioning. We cannot overemphasize that in this time of epidemic, that even if we have the capability in our hospitals to do level 1, I think it's unjust for our patients to expose them to the danger of being in a hospital environment for benign disease that can be postponed with no consequences. Because the mere existence in this hospital environment is a danger by itself, and that all patients that are going to surgeries, they should have be screened for COVID, because even if they are asymptomatic, it has been shown that mortality can be quite high, up to 20–25%, even if they are asymptomatic, but they are COVID positive. So screening is quite important.
Yeah, and I mean, what's interesting is that there are things that will come out of this that will be utilised and will provide a better patient care. We have learned a lot, haven't we? How we select patients and who we operate on and how we do things and how we communicate and how we work. In the UK, we've been doing a lot of virtual remote consultations, video consultations, and on the phone. And our elderly patients in neurology, because in neurology we have a lot of elderly patients, they have really appreciated not coming into the hospitals. So we have run mainly remote clinics now for about 2 months, and I think we'll continue to run a hybrid system of hybrid, meaning some face-to-face and some virtual. It's not ideal for everything, but you know, and theatres will run slower because of PPE, etc. But I think it's important as surgeons. I think we've shown ourselves not to be the kind of gadget freaks that some people think we are in terms of laparoscopy and robotic procedures. I think it's important that we do, you know, the right thing at the right time, you know, for the patients. And I'm not sure in the Middle East how I'm sure you've been the same as we have, that, you know, we've been doing what we need to do, and we've had great support from the patients.
Thanks. My colleagues?
Ashraf and Dr. Sami Suleiman, can I have a few minutes? Just I want to discuss a few things with Dr. Ebster for the laparoscopic nephrectomy and partial nephrectomy. It's very crucial for the people who's starting to plan it very well with a CT scan. You have to review your CT scan. You have to make sure how many arteries, with the location of the hilum. I always, the night of the surgery, I review the CT scan. I plan my surgery. If the tumor is upper pole, the tumor is lower pole, where is the hilum? I'm gonna face the artery above, below the renal vein. All of these are very crucial when you plan your procedure. So CT scan is very crucial, and I always open the CT scan intraoperative and review it. So when I go up into the ureter, I go and review the CT scan. I see exactly where is the renal vein, where is the renal artery. No surprises. So this is the way. The other thing is, when you start, don't start crazy. I mean, you have to make sure that you start with a smaller tumor, not a complex patient, and get someone with you to help you with the first few cases. The question that I have a concern, I agree with you, to be about using the clips, the GIA over the renal artery and the renal vein. I got burned once again for device failure.
Me too.
Yeah. So I stopped using on both artery and vein. But we have our colleague, Dr. Zahrani, who is doing a lot of cases. He has a good experience with doing the hilum together. So what he does, he go above the renal hilum, go to the finding the psoas muscle, below finding the psoas muscle, and in between he put the endo-GIA and fire on both. I've done it a couple times, but you have to make sure that the hilum is thin. I mean, there is no lymphatic, no lymph node, no reaction, a lot of reaction, because that will make the renal hilum very thick. And you have to use the proper stapler length. So don't use the 35, which is 3.5 centimeter. You have to use the 45 or 60 to make sure that you're coming all the way to the end, so you don't leave anything behind.
I totally agree about that point, Adil. This is should be emphasized, actually, that the actual staple type is very important. They are not created equal. Some of them is for thick tissue, some of them is for thin tissue, some of them are for vascular stapling.
The white, the green, the blue.
So you need to use those, the proper stapling, length and width, both. And this is very important. I use the same technique, as you know, that above and below the hilum, create your windows and fire on everything. But if there is no intervening tissues, as you say, this is very, very important.
Yeah, so I have a colleague who does exactly that, and it's a fundamentally different way of doing a nephrectomy. He does exactly as you've just both described. He goes above, starts below, and then he goes above quite early and creates a window, and then goes around the back. I think he has evolved from an open way of operating, whereas I am very methodical in finding the artery. Find the artery, find the artery, find the artery, find the artery, go around the back, find the artery, find the artery. I think that, you know, that's the way I do it. I have used the stapler. I use a 45 millimeter, I use a vascular stapler. And every time I think I miss a few. I have palpitations every single time, wondering whether it's going to fire or not. Because on one occasion it didn't fire, and I have used it to get myself out of trouble. I will often staple the vein. I'm more comfortable just stapling the vein if I've got a really wide vein. Sometimes you get a whopping renal vein, and even your extra large gold Hemalot clip, you're not confident. I mean, you can pinch it up. Some people put a suture around it and tie it, but I've sometimes stapled that. But I think it's a really important point. I don't think you should be stapling early on. I think you need to be methodical, clip the artery, and then clip the vein, because you can get into
especially when you start, especially when at your starting point.
Yeah, you are right, because I came from an open background, and I used even to staple while I'm doing open surgery. So I'm that comfortable. Adil comes from the laparoscopy background, so he's exactly like yours.
Exactly, no right every single step.
Yeah, there is no right or wrong. Do what's exactly what you are comfortable with and what you are familiar with. This is, I think, the key issue here is that there's no right or wrong. If you are already familiar and comfortable doing something, keep doing it. And don't try things that you are not comfortable with.
And the other thing is, Ashraf, as you said, it's practicing. So why do I do 10 transperitoneal and then I start mastering and then change to retroperitoneal? No, you have to do exactly the same to make sure you cut the time. So I do lap transperitoneal. I always use the same step in every case. That will help me to move forward, progress faster, to learn. Once I master it, then I will learn something, a new technique to keep it as a backup. But it's always, you have to use the same thing all the time to practice, to master it. So don't jump, you're doing the artery, the vein, and then the next case you do the bulk, and then the next case you do something. It's better that it's done all the time, the same technique. You practice the same technique until you get excellent in that point. So this is one way of learning laparoscopy. It's like when you do the lab, when you do in the lab, the dry lab, you practice the same thing many times until you master it. So this is the way. You start by doing smaller cases. You start with an expert, and then you continue doing exactly the same technique. If I do varus, then I practice the varus until I'm excellent in the varus. I used to do open all the time. I trust the open. I feel very comfortable when I do the open. Still, it's not 100% safe. You have to know that, but it's feel comfortable. Now, when I start doing laparoscopy, robotic, I start doing more varus needle. So I do both. I feel that the varus needle is safe in this patient, I do the varus needle. If it doesn't go from the beginning, then I immediately shift to open, and it goes fast. So it's like hybrid. You have to know both technique, but you master one of them.
So that's exactly right. And that's the point I tried to make earlier on. And it's quite a difficult thing to articulate, that as surgeons, particularly with laparoscopy, you've got to be very pernickety in what you do and very fastidious, but you've got to be flexible. I mean, for a start, you've got to be ready to convert. Don't be frightened. Don't be proud. If it bleeds, you need to convert. You need to convert. It doesn't matter. The patient's safety is absolutely paramount. So you need to be fastidious, but you need to be flexible. And as you said, and I didn't go into this, but in terms of when you start, what we tend to do in the UK is we have a mentor, or we've moved on from sort of having a mentor, a highly experienced. So I had an experienced a retroperitoneal surgeon who came to help me because I'd done transperitoneal surgery as a general surgical trainee. But what we've evolved is having two consultants co-operating with each other and holding the camera. But what you learn is that some consultants are not very good at holding the camera, and they're not very patient, and they want to look at the spleen when in fact you want to look at the but managers don't often understand how important that cameraman is. That cameraman is absolutely vital. It's not one surgeon who is wonderful and other people. It's a surgeon and the cameraman is incredibly important, and you need to have that reproducible. So we get signed up, we go through a process of training and then being signed off by the mentor, because, you know, when a laparoscopic nephrectomy goes nicely, it's wonderful, isn't it? You know, 2 hours, maybe 1 hour, patient goes home in under 24 hours. But when there's a problem, it can spiral out of control.
It is a serious problem.
So it's about being sensible. So you're all saying what I completely agree with, that case selection is really important. What you said about CT, you sound very much like me. I go to bed at night thinking through the steps of what I'm going to do the next day, particularly with a difficult one. And have the CTs available in theatre is really, really important. Some people have planning meetings. So we, you know, we have a renal planning meeting. I don't think you can just turn up on the day and however good you are, have a think, you know, ask your radiologists, go through it. Exactly as you said, how many arteries? 1 artery, 2 arteries, 3 arteries. No, anticipate what you're going to get, and that's what becomes safe.
I have just a few comments on using the ultrasound in the cases of partial. Now, I don't have the ultrasound, I got it, but I think it's very crucial that we use it in every single case. If you want to master how to use it, then it's easier to use it in exovitic small mass, just to start practicing. So it's a matter of practicing. You know that sometimes when it's small, that it takes like 10 minutes to take it out and suture, because it's exovitic. It's practicing, good to practice use the ultrasound in every single case. By this, when you come to complex masses, you'll be mastering at least, or you know how to use the ultrasound. No,
well, I mean, you make a very good point. You obviously didn't train in the UK. You must have trained in Europe or
Canada.
Canada, yeah, I was going to say North America, because they're very much in favour of it, and I see why. And it's like everything, you know, I'm not very good at it because I haven't done it very much. And if I'd done it every case, which the proponents of it say, obviously you are going to get better. And yes, I think it is a nice piece of kit to have, and when it works well, it's one. I agree. If you've got it, use it all the time, every case.
And for doing robotic for radical nephrectomy, we know that it's not cost effective. We know that doing a laparoscopy, it's more cost effective for radical nephrectomy. But I think doing radical nephrectomy robotic will train you how to handle the hilum. So I feel, I don't know, but I feel more comfortable doing partial than doing radical. Radical, because you are like playing with the hilum, you want to dissect the hilum completely and clip it. And so the chances of bleeding is higher from the hilum. It's higher with the radical nephrectomy. But partial nephrectomy, for me, I don't use the yellow rubber thing. It's what do you call it?
Sloop.
Yeah, the loop. Yeah, the vessel loop. I don't use it. I usually just find the artery anteriorly, make sure that the clip goes smoothly. And based on the CT scan, if this guy has a lot of atherosclerosis in his aorta and his arteries, then I expect that the renal artery will be more stiff. So that's the point when I use two bulldog clamps. I don't like to go around a lot around the artery and the vein in the partial, because that's the time when you might cause bleeding. But I like to go with the bulldog clamps, and I like to use the robotic in both the nephrectomy and the partial, just to train yourself how to handle the renal vessels. I know it's not cost effective, but at least in the beginning, if you want to master the partial more, I think it's better that we go do radical nephrectomy and more simple nephrectomy, even with robotic. It will help you in pushing your training and learning experience.
Yeah, I agree with you. I think that the radical nephrectomy can be really quite difficult robotically, and partly that's because you've got to work your way over a large distance. You've got to go from you've got to go from iliac fossa up to upper quadrant, and that you know, that's quite difficult.
with the robot.
But it makes you better and at doing that, and it certainly helps you get up the learning curve. So that's what we did. So we did radical nephrectomies on the robot, so that not only the surgeon but the scrub team and the assistant could get used to, because it's numbers. And as you say, you know, a lot of partials are a lot more straightforward than the radical. Some of the radical nephrectomies are devils, aren't they? You know, with nodes around the hilum and what have you.
Actually, the most devilish out of all of them are the simple nephrectomies.
Yeah,
and those are the nightmares.
Nothing simple about that.
I've had two simple nephrectomies which were horrific.
It can be hell, actually, especially when xanthogranose or something like that.
One adherent to the IVC and one adherent to duodenum. And I'm very grateful to my vascular colleagues and to my upper GI colleagues. Don't underestimate the benign stone nephrectomy. But I think the panelists obviously are all aware of that. But hopefully to everybody else, the small you know, you don't have to be offering a partial nephrectomy on every, you know, tumor under 3 or 4 centimeters. Sometimes patients like to have a total nephrectomy for cancer clearance. They're the good cases to do. Not the stones, not the renal pelvis stone, with, you know, that's been there quite a few years with perinephric stranding, and they can be awful. I mean, they can come out quite nicely, but you never know, and it's very difficult to plan it from the CT.
Definitely. There's a question about the patients with multiple small tumors and multiple partial nephrectomies simultaneous in the same kidney. For example, we have a clear example with the VHL patients, and I have like a group of them. And what's your experience with that? Do you have an experience with those?
So what we tend to do with VHL is, if they've come into the program early and they've got small tumors, in the UK increasingly we're ablating them. We're using cryoablation for tumors when they get to 3 centimeters. I have only done a couple of cases robotically of simultaneous multiple partials, but they were quite small and they were near to each other. But otherwise, with a multiple tumor, if I was going to do partial nephrectomy, I'd do it open. But the principle in the UK is, if they're small, only when they get to 3 centimeters do we treat them, but we tend to try and ablate them. So I personally am not somebody who's got one of these large series of multiple reaccess partial nephrectomies like someone like Tim O'Brien at Guy's has got. I haven't got that. In our centre, the VHL patients have ablation.
Because the ablation techniques in our country in general are not that, didn't have that great and so we do a lot of these. We used to do them open. Once they reach 3 centimeters, we remove the lead tumor and the rest of the superficial tumor. But now we are doing them more and more robotically. And these are maybe a little bit challenging.
How do you, is that trans retro, or do you change, or how do you do it?
Transperitoneal.
So you do them all trans, yeah.
Yeah.
I mean, I bet some of them are quite straightforward, but I bet there are others that are extremely challenging.
Definitely.
I think ablation is good. You know, I think it's a good technique. We've gone through a phase of doing RFA, but I think the cryo is better because you get the frozen ice ball at the time on imaging, so they can see what they're actually ablating, and so they get less collateral damage. I think with RFA, we've had quite a few, particularly lower pole tumors. We've had thermal damage to ureters and to bowel. So it is not a straightforward technique, but I think for people who are trained in it, the radiologists who are trained in it, I think cryoablation is the future, personally, for small renal masses in those patients, and particularly. I'm interested to hear, did you have a centre dealing with VHL? Because in the UK, we have a few centres where we sort of concentrate the VHL practice, because they get adrenal tumours and cerebellar tumours and retinal tumours, and they all the genetic testing, they need to be in a very high-tech dedicated centre.
Yeah, not formally, but once you are known for something, they start referring those patients to you. The other thing is that, unfortunately, we don't have a lot of centers that have cryo, and RFA, in my opinion, is not the best ablation technique for renal tumors. The high recurrence rate and the damage, the margins of that damage that you are ablating is not as good as the cryo. You cannot tell where are you really working as in cryo. So this is why RFA is not the greatest ablation technique. Do you do that percutaneous, CT guided, or laparoscopy guided?
Yeah, so that's all done CT guided. I have not done any laparoscopic ablation. There are some people that do, because the potential worry is the anterior tumours with the bowel. But what the radiologists tend to, I don't know how they do it. I keep meaning to go and watch, but they use a term hydrodissection. So they put some instrument in, and they hydrodissect the duodenum or the colon off the kidney in real time on CT to give themselves more of a space and margin to be able to do the anterior tumours. They make it sound very easy. I don't know if it is, but I must go and watch.
Very interesting.
Yeah. But no, I've not done it laparoscopically. I know there are some people who are still doing laparoscopic cryoablation for the anterior tumours. Our interventional radiologists are really becoming very skilled in many techniques, embolization, and that's something else we must say about partial nephrectomy, is that you must have expert. Ideally, you have expert interventional radiology support, because when patients bleed after, and it's normally within 12 hours or so, the gold standard of care is, as long as they haven't bled significantly and are shocked, in which case they need to go back to theatre, is that they have CT angiogram with a view to selective embolization of those vessels. It's normally just a single vessel that hasn't been sutured, and that's done by the interventional radiologist. So we have those that facility in our suite. I don't know if that's your practice there, but I would suggest that that's an ideal backup.
Okay, so we are coming towards the end. Any comments or questions from our panelists?
Dr. Sam, go ahead.
Yes, I would like to ask the professor if you have any problem in harvesting a graft for transplantation. Do you have any problem with longer ischemia, which is usually accompany the laparoscopic retrieval of the graft compared to open surgery? Because I mean, with open surgery, you have a definite short time in recovering the kidney, but for laparoscopic surgery, do you think this is the warm ischemia is longer and may have any impact on the transplant graft?
So I do no transplantation, so I've got no experience in that myself, but I have colleagues who are utilizing laparoscopic techniques and now robotic techniques, although it is quite challenging and requires a lot of multidisciplinary interaction between the laparoscopic surgeon and the transplant surgeon, as well as the nephrologist as well. But my understanding is that as long as it's all planned properly and appropriately, my understanding is they're getting good results, and that's being translated into good graft function afterwards. But I don't think it can be underestimated how challenging a a procedure it is, even laparoscopically doing live donors, because the stakes are very high. So our surgeons went to I can't remember one of the centres in India. They went to India where they were doing robotic live donors, but I think they're having pretty good results. But the important principle is it's a very challenging procedure, isn't it?
Yeah, Adil comes from, I think, a center that they do a lot of laparoscopic donor nephrectomies,
Yeah.
and it is the standard of care now. So if you look at the guidelines, the donor nephrectomy is the standard of care. Is laparoscopic or minimally
Yes.
invasive, isn't it?
Yeah, it is.
So Adil, can I have some of your comments and experience in your center?
Yeah, they start doing more even single port donor nephrectomy, and they as you said, it's a practice. Once you master those, you can cut down your warm ischemia time to a few minutes, like immediately. Once you cut the renal artery and the vein, the kidney is already dissected. You have a gel port. You can put your hand there and retrieve the specimen. It takes like 2-3 minutes, the warm ischemia. So it's not that major, unless you have a problem like bleeding during your artery clamping. And that's the time when your warm ischemia is more. You have to control your bleeding and you're worried about the kidney, but that's it. You have to save the patient. So it's always very, very stressful to do laparoscopic donor nephrectomy. And as in Canada, they used to have 2 surgeons all the time, one general surgery, one urology, and they alternate. They do the nephrectomy alternating between them, which is, I see it is very valid because of the stress of doing this case. One more thing, if before, I think we have a few minutes left, is about the adrenal. We didn't talk about the adrenal at all. The question is, now it's everywhere. Who's supposed to be doing adrenal? Is it urology or general surgery? In Canada, I have to say, in Canada, it depends on the center. There are some centers, it's always general surgery. They refer the case to them. Urology are not allowed, and they don't have that experience. Some other centers, I was lucky during my fellowship, I've done the adrenalectomy. And when I came here, I used to do a lot of adrenalectomy. So even larger size and right side. And I think it's very important to keep that practice to urology, because we see the adrenal all the time when we do nephrectomy. So we still know the anatomy, we still know the axis, and we know the pathology. So why, I don't know a practice in the UK. Is it general surgery or urology?
That's a great point. So I didn't talk about adrenal because I don't do them anymore, because they are increasingly not done by urologists. They are done by endocrine surgeons.
Yes.
And I don't quite understand what an endocrine surgeon is, but why should you operate on the thyroid in the neck one day and the next day you operate on the adrenal? But so they've been increasingly taken away from us, and I completely agree with what you've just said, because we see the adrenal. It's part of the planning of urological surgery, of renal surgery, and it's really nice surgery to do. And you get better and better at doing your upper pole. When I first started to do robotic nephrectomies, I found it quite challenging doing the upper pole, but as you do adrenals, you get better and better of knowing the anatomy there.
Yeah.
On the right next to the IVC and the left, the spleen, etc. You clearly need input from the endocrine people in terms of blocking the theocry. Never. I mean, I've done a pheo not knowing it was a pheo, and that was all quite stressful, mainly for the anaesthetist. But so in the UK, adrenals are now pretty much not done by urologists, which I think is a great shame. It's a lovely operation, transperitoneally, and retroperitoneally, but transperitoneally. It's and I see no reason, if you're a competent laparoscopic surgeon and you're doing renals, I see no reason why you shouldn't be doing them if you're able to. In your centres.
Great.
Any more comments or questions?
No, I think that's it. It was very great,
So,
I have to say.
Thank you, everyone. It was very nice to meet you today, and it's very informative, Professor Dr. Webster, for your presentation today. And it was nice to meet you all. And since last I saw Dr. Ashraf and Dr. Adil, maybe in Jeddah, the Urology Club, before, when I was in United Doctors Hospital before. But it's nice to meet you all today.
Thank you.
thank you.
Thank you. Thank you.
It's always a pleasure to have somebody in your caliber and your experience to share his knowledge with us. And you are always welcome to Saudi Arabia and Jeddah. We should have you sometime. We have a lovely city here, and you will really enjoy it, and you will honor us.
Well, thank you very much. You flatter me, but I can tell from the panel you're all pretty experienced surgeons. You know what you're talking about, and with Dr. Mustafa I've met, and it's very nice to see you again. But yeah, I can tell
thank you very much.
You all know what you're talking about. I mean, I am associated with Saudi German Hospital Group as a visiting professor. So I've never been to Saudi. I've been to the Middle East. My in-laws live in Oman, so I visited Oman and Dubai. But it'd be nice to continue a collaboration. But I'm impressed, with the knowledge of the panel. I hope I've imparted some knowledge to you.
A lot.
But I can tell you have a great background of knowledge yourselves, and I'm flattered that you asked me to do this. So thank you very much. And particularly, it's quite late for you guys, so I hope you have a nice.
It's all about sharing experiences, and whoever thinks that he's at the top, I think that he didn't reach anything. So all of us learn from each other, and it's a continuous process.
Exactly.
It's an honor, and we thank all our attendees. We reached sometime over 550 attendees. That's great. And hopefully this will be repeated, and we can.
Adrenal.
Yeah.
We have to get that.
Adrenal.
I'm pro this.
I'll moderate adrenal if I haven't done one, even if I haven't done one for a while. I'd like to see. Yeah, definitely. And
we have actually, me and Adil did a few together, some very nice cases.
Very difficult.
We did
was nice.
I think like 10 of them in a year.
10.
It becomes nice retrograde when you finish them and you think it over, but when you're doing it, it's not nice at all sometimes.
Yeah. I mean, the little one, some little ones that are like 20 minutes, and you think, oh, that was easy.
Yes.
And then some of the retroperitoneal larger ones can be very difficult. But I think it's done. I think
especially functioning phacocytomas, it's really challenging.
It's all about the blocking. So it's important that urologists don't do it in isolation. If urologists are going to do it, they must do it with their endocrine, physicians. That's really important in terms of the blocking preoperatively. But no, we'll do one on adrenal. That would be really interesting. I must say, thank you to Saudi German Hospital Group. And
actually, on behalf of Saudi German, we need to thank you, Professor Webster, and we are looking forward really to see you in Jeddah as soon as the fight ban will be over, and to have more interaction with the colleagues here in Saudi German Hospital, Jeddah, and Saudi Arabia in general. Really, it was a pleasure having you with our panelists, and thank you, Dr. Adil Ammari, Dr. Diaddin, and Dr. Ashraf Samrab for the very exciting and interactive session. And we look forward to repeat it again with more topics to come. And looking forward to visiting Saudi German Hospital, Jeddah, and Saudi Arabia.
Great. Well, thank you. Thanks for the panel. Have a good
day. Thank you all. And I want to thank Dr. Sami Sulaiman and Dr. Diaddin, Dr. Adil Ammari, and our guest of honor, Dr. Guy Webster, and to all our attendees. It's always great. Hopefully we'll see you soon. And thanks a lot, and have a good night.
Thank you. And stay safe, everyone. Thank you.
It's always to see you.